delivery. And regard the changes of cardiac output, it usually increases 30 to 50% above the baseline during normal pregnancy. The degree of changes is acutely influenced by posture, as the cardiac output is higher when the pregnant woman in the left lateral decubitus position, especially later part of pregnancy. By comparison, assumption of supine position can lower the output as much as 25 to 30% due to compression of the inferior vena cava by graviductors. The increase in cardiac output results in change in three important factors that determine cardiac performance. Preload is increased due to associated increase in blood volume. Afterload is reduced due to the decline in systemic vascular resistance, and maternal heart rate increase 15 to 20%. That's why you will hear a common complaint during antenatal follow-up that patient is having palpitation. So it's normal physiological changes. In regard to the blood pressure typically decrease during early gestation, and usually it's 10 millimeter mercury below the baseline. In the second trimester, decline to a mean of 105/60. This response is induced by reduction in systemic vascular resistance, which appear to be parallel changes in afterload. In regard to physical examination, normal physical findings may include distended neck veins, some RAS, a prominent left and right ventricular apical impulse, exaggerated heart sound, and a new systolic ejection murmur that best heard over the mid or lower left sternal border. Peripheral edema will be present in the last trimester. So how to differentiate between the physiological edema and the DVT? Excellent, okay.
There is pain maybe.
Pain, tenderness, temperature, erythema. Excellent, unilateral or bilateral. Excellent. EKG changes, shortening of PR and QT interval may accompany the increase in the heart rate. What are the risk factors for developmental of heart failure? So if you have a patient, she's a no case of cardiac disease, she's a pregnant, why some will develop heart failure and some will not develop heart failure? What are the risk factors, you think? Good job. Other comorbidities, excellent. Any comorbidities like hypertension, diabetes, autoimmune disease, renal disease, what else? Obesity, always obesity as a risk factor for everything. So always, if you mention obesity, you will not be wrong. What else? Infection is causing a stress, right? So respiratory urinary infection, anemia, obesity, corticosteroid tocolytics, multiple gestation, because it will increase the load on the heart with the multiple gestation, hypertension, arrhythmia, pain-related stress, and fluid overload. That's why always you will find the recommendation by the cardiology for a pregnant lady with a cardiac disease to avoid overload, especially during labor. So essential point of examination pregnant women with a heart failure, we have to check pulse and rhythm, blood pressure, jugular venous pressure, presence of crepitation, ankle and sacral edema, and symphysis fundal height measurement. Why symphysis fundal height measurement is important?
To check for IUGR.
Excellent. So it's a screening for IUGR. It's not diagnostic, but it's a screening for IUGR. And the patient with a cardiac disease more prone to have IUGR maybe. Fine. Assessing risk, women with acquired heart disease may have cardiac complications during pregnancy. The risk can be assessed by evaluating the severity of the valve lesion and the degree of ventricular dysfunction. A history, physical examination, echocardiogram, and EKG form a foundation of cardiac evaluation in all patients. So always history examination like any other patient, and EKG for the cardiac patient. The following risk and predictors for maternal and fetal complications in women with congenital heart disease during pregnancy have been identified. If a patient having pulmonary hypertension, maternal cyanosis, poor maternal function class, history of arrhythmia, and maternal anticoagulation. So we'll start with preconception, antenatal, and intrapartum, and postpartum. So regarding preconception, evaluation prior to preconception counseling include identification of any markers of increased maternal cardiac risk, as as determined by history, examination, EKG, and echocardiogram. So if you have a patient, she's a cardiac, and she's planning to get pregnant, and she's coming to you preconception, what you will advise her?
Lifestyle modification.
Excellent, like lifestyle, like what?
Weight loss, exercise.
Excellent, if she's obese, so decrease weight.
Folic acid.
Folic acid, excellent, has to be started like 8 weeks before pregnancy. Excellent, so folic acid for any any patient planning to get pregnant. What else?
Take the vaccinations.
Vaccination, excellent. So weight, vaccination, تفضل.
Smoking.
Excellent, smoking. So to stop smoking if she's smoking. What else?
Maybe if they use other drugs like ACE inhibitors.
Excellent, ما شاء الله. عندكم الليكتشر؟
No, no, man.
Excellent. So if she's using any teratogenic medication to shift to non-teratogenic medication. Excellent. But so at the time of prenatal counseling, attention should be paid to a smoking history and the use of medication that may be potentially teratogenic. Angiotensin converting enzyme inhibitor and angiotensin 2 receptor blocker are contraindicated during pregnancy and should be discontinued during pregnancy. Women who are receiving warfarin therapy should have the opportunity for counseling to be shifted to non-teratogenic medication like low molecular heparin or heparin. Right, issues in pre-pregnancy counseling of women with a heart failure. So patient should be counseled regarding risk of maternal death if she's a known case of severe cardiac disease like pulmonary hypertension. Risk of miscarriage. Okay, so always counseling patient for complication of a disease during pregnancy, either to divide it to maternal and fetal or first trimester, second trimester, third trimester. It's up to you. And for me, I prefer first to second, third, and not to forget. If it's like first, you will remember what could happen the first trimester, مثلا miscarriage, congenital anomalies. بعدين second trimester, what could happen in second trimester, preterm labor, intrauterine growth restriction, وهكذا. طيب, risk of fetus developing congenital heart disease if she's having congenital heart disease, not acquired. Okay, risk of preterm labor, fetal growth restriction, need of a frequent hospitalization, and possible admission to ICU. Right, so management during antenatal. I'll slide Fabio, so I need your help. So antenatal. So you have a patient, she's coming to you, she's 8 weeks pregnant, she's a known case of cardiac disease. What you would do in the clinic?
Take history.
Okay, take history, excellent. So history, examination, and then we have to order labs. صح, the routine labs, which is CBC,
Coagulation factors.
coagulation profile,
Profiles.
blood grouping. Why blood grouping is important?
RH.
Excellent. For RH incompatibility
And for bleeding.
and for bleeding later on. Yeah, excellent. What else?
Renal
Renal
function.
function.
Liver function.
Urine culture as to treat asymptomatic bacteriuria. صح, and serology. Rubella, hepatitis, syphilis, right? So apart from blood test, what test you want to order?
Echo.
قلنا urine culture analysis. Excellent. Echo and EKG. صح؟ كنا قلنا echo and EKG with the history and examination. And involve her primary cardiac physician. Okay? Her cardiologist. طيب, and then she's pregnant 8 weeks. Would you do ultrasound? صح? So what's important of ultrasound at 8 weeks?
We found the
Neural tube defects.
8 weeks?
no
متى nuchal translucency?
at 10 to 13
Yeah, 11
11
to
to
14.
14.
Okay.
Viability.
Excellent. Viability.
and the location.
Location, intrauterine or extrauterine.
Dating.
CRL, yeah, dating, excellent.
If there is any previous.
Neural tube defects.
Still early. هذا for congenital anomaly. صح, baby is 8 weeks كده.
and the number of
Excellent. So
pregnancy.
singleton or multiple. Okay. This is the first scan. And then, as you said, 11 to 14 weeks, the nuchal translucency, which exclude 70% of chromosomal anomalies or congenital anomalies. Okay. And then, what kind of ultrasound in second trimester? Excellent anomaly scan, 18 to 22 weeks to exclude any anomaly scan like neural tube defect or any cardiac anomalies. And no, if the patient is having congenital anomalies, the baby will be more prone to have congenital cardiac effect. طيب a routine of any patient cardiac disease, pregnant, congenital cardiac disease, we have to order fetal echo to exclude fetal cardiac anomalies. طيب then the patient has to be seen every 2 to 3 weeks to exclude with ultrasound to exclude intrauterine growth restriction. طيب this is regarding antenatal. So clear? So it's the same like a regular antenatal, but you have to add more ultrasound, frequent visit, and she's at risk of having intrauterine growth restriction, baby, preterm labor, and the other complications. Right. So management of labor and delivery, again collaborative management by obstetrician, cardiologist, neonatologist, and anesthesia. Why neonatologist?
For the baby, like in case he has congenital malformation.
Excellent. So for the baby, لأن احنا زي ما قلنا, if the patient have a congenital cardiac disease, baby will be brought to have congenital cardiac disease. What else?
If the baby is IUGR.
Excellent. If the baby is IUGR or preterm, so a neonatologist will be involved. Regarding anesthesia, we can use any kind of anesthesia, but usually lumbar epidural anesthesia is highly effective for controlling labor pain, and it's recommended because it lowers the pain-induced elevation of sympathetic activity and reduce the urge to push and provide excellent anesthesia for operative procedure. So usually we prefer to give the patient epidural during labor. What's operative procedure?
Forceps or doctor.
Excellent, yeah. Oxygen therapy. Oxygen is often administered during labor, especially in cyanotic women. However, maternal benefit has not been demonstrated. Hemodynamic monitoring, systemic arterial pressure and heart rate are routinely monitored during labor. Pulse oximetry and continuous EKG monitoring are utilized as required by patient condition. So not all cardiac patient in labor needs a continuous EKG. Usually recommendation by cardiologist. Mode of delivery, what do you think? C-section or normal delivery?
It depends on the baby.
طيب, if it's cephalic,
No, like C-section.
why C-section?
Because there's a lot of stress on the mother's part during that.
Because of the bleeding يعني.
C-section طيب.
We can-
هو يعني C-section during C-section half an hour there is no, but after that the pain is much more في C-section than in normal delivery, صح?
We can do operative design.
Operative vaginal delivery, why? To shortening second stage عشان to reduce the stress, right? But in general, if the patient has no contraindication for vaginal delivery and she's cardiac, so vaginal or cesarean? Vaginal, why?
We don't carry the risk of anesthesia and it's complicated.
Excellent. So risk of anesthesia, one of it. And some patient will be converted from spinal to GA, صح? During the cesarean section. Okay, what else? The bleeding. How much the bleeding in vaginal delivery?
500.
50.
500 milli.
500.
Less than 500 C-section.
1 liter.
1 liter.
So it's double, right? Risk of DVT and pulmonary embolism is more with the C-section than, right? Risk of infection is more with the C-section than the vaginal delivery. So, for nearly all gravid with cardiac disease, vaginal delivery is preferred to cesarean delivery, since vaginal delivery has less risk, less cardiac risk. Cesarean delivery is generally preserved for obstetric indication. What obstetric indication you think? That's a group. What are the obstetric indication for C-section? Abnormal?
Presentation.
Abnormal presentation, excellent, like a breech.
Placenta preview.
Placenta previa, excellent.
Prolonged duration of second phase.
Okay, يعني failure to progress.
Fails.
What else?
Abruption.
Abruption placenta, if she's still early, يعني abruption placenta, if she's already 8-9 centimeters, she will progress fast. But if she's like 3-4 centimeters, yeah. What else?
Macrosomic baby.
Macrosomic baby,
Fetal heart distress.
fetal distress,
Vaginal lesion. Uterine rupture.
uterine rupture, of course.
Vaginal lesion.
Vaginal, يعني big cervical mass, okay. Or herpetic lesion. Yeah.
Bishop score less than 6 maybe or less than 4.
بس في induction we can use prostaglandin if Bishop score less than 6 صح؟ Previous to cesarean section صح؟ لأنه risk of uterine rupture is high. طيب. The concern about cesarean section, as we mentioned, general anesthesia, if required, has more risk and of hemodynamic instability associated with intubation and anesthetic agent. Cesarean delivery has more blood loss, that approximately twice as vaginal delivery. Increased risk of wound infection and uterine infection. Post-operative thrombophlebitis is more common after cesarean delivery. The risk of post-operative incisional bleeding is high in patients with anticoagulation. Right, we think spontaneous or reduction? Spontaneous, excellent. So spontaneous onset of labor is preferred to induce labor for most women with the heart disease, pregnant women with a cardiac disease who are considered functionally normal or well controlled should be allowed to have to go into labor spontaneously. In regard to the fetal monitoring, a reduction in uterine blood flow and placental oxygen delivery typically occur during the uterine contractions. However, the fetus is adapted to extract enough oxygen to maintain fetal health. So usually a baby of a cardiac mother wouldn't be affected during labor from being cardiac. يعني baby might have fetal distress for other reasons like cord compression or whatever reason. Antibiotic prophylaxis, not all patients with a cardiac disease need antibiotic prophylaxis, depends on the recommendation from her cardiologist. So in general, management of labor in women with the heart disease, we have, as we mentioned, we have to avoid induction of labor if possible, use prophylactic antibiotic if required by cardiologist, ensure fluid balance, avoid supine position, discuss regional epidural anesthesia with a senior consultant, anesthetist, and keep second stage as short as we can, as we mentioned by vacuum forceps. So regarding postpartum care, after expulsion of the placenta, bleeding is reduced by uterine massaging and intravenous oxytocin administration. Oxytocin should be infused slowly, less than 2 units per minute to avoid a hypotensive effect. Delivery is associated with hemodynamic changes that lead to heart failure in women with pre-existing cardiovascular disease. That's why patients should be kept for observation for a few hours. Some patients will need HDU, but high dependent unit for observation. طيب. Contraception, barrier method include condom for male and diaphragm with the spermicide for female, although these methods are generally less effective than other technique, but they have no risk of complication. Combination of estrogen progesterone contraceptive like pills, patches, ring can be used in women with low risk for thromboembolic complication. Sometimes we can use progesterone only pills with the breastfeeding, but as you know, progesterone only pills, most of it's weak if it's used without breastfeeding. So it has to be used with the breastfeeding, unless it's Depo-Provera, the injection every 3 months. Tubal occlusion is not reversible, as you know, but can be done safely. Even relatively high-risk women, the risk may be even lower in the minimal invasive hysteroscopic technique. So as you know, it's irreversible, but for a patient like with a serious cardiac problem like pulmonary hypertension and she's para 1 or para 2, she should be advised to do it. But pregnancy in women with, we'll talk about some cardiac disease. Pregnancy in women with mitral stenosis. Mitral stenosis encountered in women with of childbearing age and nearly always rheumatic in origin. Maternal and prenatal complications during pregnancy in women with mitral stenosis reflect unfavorable interaction between the normal cardiovascular changes of pregnancy and stenotic mitral valve. So the more stenotic the valve, the more complication patient will have during pregnancy. In the United States and Canada, women with rheumatic heart disease, of which mitral stenosis is the most common manifestation, it accounts of less than 25% of pregnant women with the heart disease. And as we mentioned, the more stenotic the valve, the more complications you will have. Eisenmenger syndrome, it has very, very high mortality. The syndrome develops when initially there is left to right shunt across a VSD with consequent pulmonary hypertension. Most of the patients with Eisenmenger, if they come early, they will be advised by their cardiologist to terminate the pregnancy. Coarctation of aorta, the principal risk is of dissection of the aorta associated with increased cardiac output pregnancy. Risk of 2% that the fetus will develop coarc if the mother is having coarc. Question.